Guide to the graphic. Here we have depicted the heart and the lungs, and the cardiopulmonary circulation. We'll focus in on the heart first. Here we have the right atrium, with the blood depicted in blue because of its low oxygen content. The blood then flows through the tricuspid valve into the right ventricle. The blood is then pumped through the pulmonary valve out to the pulmonary arteries of both lungs, where oxygen is picked up and waste products are gotten rid of. Then the blood returns from the lungs to the left atrium via the pulmonary veins, travels through the mitral valve into the left ventricle, then is pumped out of the left ventricle via the left ventricular outflow tract through the aortic valve and out to the body. Heart failure. Heart failure occurs when cardiac output is unable to meet metabolic demands. It cannot be defined numerically in terms of cardiac output or ejection fraction because metabolic demands vary from patient to patient. Compromised systolic or diastolic ventricular function, or both, resulting in elevated ventricular end-diastolic pressure, may lead to heart failure. While isolated left or right-sided heart failure is not rare, combined left and right-sided heart failure is more common. Heart failure is common in patients older than 65 years of age. Its prevalence rises exponentially from the 6th decade. It has become more widespread over the past 2 decades and is now the most common diagnosis in elderly hospitalized patients. Heart failure is usually eminently treatable in older as in younger patients. Etiology. The principal causes of heart failure are divided into 4 categories: impediments to forward ejection, impaired cardiac filling, volume overload, and myocardial failure. About 75% of cases in older persons occur in association with systemic arterial hypertension, which impedes forward ejection, and with coronary artery disease, which leads to primary myocardial failure. Despite the high prevalence of clinical coronary artery disease in older persons, about 20%, about 1/3 to 1/2 of elderly hospitalized patients who died of heart failure had no postmortem evidence of myocardial infarction or of significant coronary artery disease. Valvular disease may contribute to impaired cardiac filling or volume overload. Dilated cardiomyopathy and high output failure are less common in elderly patients. Pathophysiology. Typical age-related changes such as increased interstitial fibrosis, prolonged myocardial relaxation, and increased collagen cross-linking make the older patient's cardiovascular system more vulnerable to a number of systemic illnesses. Exacerbating factors include non-compliance with medication regimens, use of non-steroidal anti-inflammatory drugs, infection, hypo or hyperthyroidism, anemia, ischemia, hypoxia, and hypo or hyperthermia. The heart adapts to increased workload through one or more of the following mechanisms: increased sympathetic stimulation, myocardial hypertrophy, or the Frank-Starling mechanism. With the Frank-Starling mechanism, the degree of end-diastolic fiber stretch within a physiologic range is proportional to the systolic mechanical work expended in the ensuing contraction. Because myocardial and vascular responsiveness to beta-adrenergic stimulation is reduced with age, and because recent data suggests that the myocardial hypertrophic response to a given increase in afterload is impaired, the elderly depend more on the Frank-Starling mechanism. Diastolic dysfunction. A prolonged myocardial relaxation time with an increase in myocardial stiffness, which decreases filling rate or volume, causes elevated left ventricular diastolic pressure at rest and during exercise. Thus, pulmonary and systemic venous congestion may occur and produce symptoms of heart failure even if systolic function is normal or nearly normal. And that is heart failure. Have a great day.